Okay, for monitoring review, it said for each reflex, describe how we perform it and what are we looking for during assessment. And what the way I like to answer this is, how do you do this? How do you assess? Um, there's what do they do when they're awake? What would you expect? And then what happens when they're anesthetized? So the palpebral is touching at the medial canthus looking for a blink. Now, when they're awake, they should blink. And in anesthesia, this is expected to be diminished in stage 3 plane 1, gone in stage 3 plane 2. So we don't want them blinking. And obviously from stage 3 plane 2 on, it's gone. And then corneal is either, you're applying something to the cornea, the surface of the eye, either an eye drop or a moistened Q-tip. And we are assessing for a blink or retraction of the eyeball, kind of like they pull it back. This one should be gone about stage 3 plane 2. So, it's present. It's a little more sensitive in horses because horses palpebral can sometimes be not as accurate. So I talked about in horses, they like to use the corneal reflex. I only tend to use it if I'm really, really concerned about brain function, head trauma, so I don't tend to do a standard corneal reflex on every single anesthetized patient. But the palpebral I use all the time. Pedal reflex is done by pinching the toe or the toe web, in between the toes. You expect them to withdraw the limb. So sometimes people call it, it's not the withdrawal reflex, it's really the pedal, but they should withdraw the limb. Obviously, this is present awake. It's diminished in stage 3 plane 1, gone in stage 3 plane 2, because if they can feel you pinch a toe, they're not ready for surgery. And remember, stage 3 plane 2 is surgical anesthesia. And then laryngeal, this is, when something touches the larynx, like the epiglottis or the larynx, which is really the arytenoid cartilages. The larynx is the whole structure. But if anything is touched, they should close. And kind of swallow goes with this. If they, if something touches, they're going to close and you may see swallowing. So this should be gone about stage 3 plane 1, because you have to put, that's when we pass the endotracheal tube. And obviously from stage 3 plane 2, it's gone. So we don't want a laryngeal reflex, but you assess this by either observing the larynx or touching the area, usually with an endotracheal tube is what we're, that's how you assess it. And obviously if you can pass the tube and they don't try to, cough, or they don't try to clamp down, then they should be good to go. And pupillary is when we shine a light into the pupil and we're looking for pupil constriction. And you're also assessing, are they equal and reactive? So you're not just assessing one pupil, the other pupil should do the same. This will be slightly present. This is about one reflex. It'll kind of stick around in stage 3 plane 2, but it should be diminished. You don't want the pupil to, if the pupil rapidly reacts to light, then they're probably not adequately deep. And obviously it becomes extremely diminished in stage 3 plane 3 and on, where they would be fixed and dilated. So if there's no response to light, then they're probably getting pretty deep. And again, it's not one I use routinely. The other thing I did not put on here, but to review, is general muscle tone. It's not, muscle tone isn't a reflex, but obviously if an animal is awake, they don't let you open their mouth. When you feel them, they just feel like they have tone. And when they fall asleep, in stage 3 plane 1, if you're holding for intubation, you should be able to open their mouth and pull out their tongue. And when you guys sedate for radiology, sometimes I'll try to open their mouth and I'll try to pull out the tongue. And if they resist, they're like in stage 3 plane 1, so, and it begins to get very relaxed. In stage 3 plane 2, they should have no jaw tone. So the best way for me to assess muscle tone is to the muscles of the jaw. I mean, sometimes, like I said, when you get experience and you just feel a patient in your arms, you feel them. If they're very, very relaxed, they're much deeper. And when a patient starts to wake up from anesthesia, they're going to start to shiver and they're going to start to get tone and they're going to feel like they start to have tone. But you really assess it using the jaw. Okay, so for each stage and plane, what do we see? Stage 1 will vary. This is awake to deep sedation. So like when you guys sedate for radiology, your patient should be in stage 1, but they're probably going to be in deep stage 1. Now, this is when we give like the pre-meds and we're kind of sedating them before surgery. And again, depending on the protocol, you can get varying levels of sedation. So stage 1 will vary. Now, stage 2 is that excitement phase. And this is the shortest. I mean, they should 30 seconds to a minute. You know, they're disorientated, they might be howling, they're dysphoric, paddling. It's kind of like they're going through the levels of consciousness. They're going from awake to asleep. It's kind of, remember I kind of called it like purgatory. You have heaven and hell, and whether you're religious or not, sometimes people understand that analogy. There's kind of like the middle. As we go from a sedated patient, and this is when you're starting to administer the propofol. You know, in stage 1, you place your catheter, and then you start to give your propofol. And if you do a really good induction, you should pass right through stage 2. You may not even see. That's a good induction. Now, I mentioned briefly, you know, we haven't talked about gas anesthesia, but if you mask a patient down or you use like a kiddie box, they're gonna go through excitement. So, you know, those inductions, inhalant induction, you tend to see more of the stage 2 than you do with like injectables like Cat-Val or propofol. And again, you want to get them through this because cardiac dysrhythmias, it's very stressful on the patient. So we want to get them through. A little tip, when I give propofol, if you're giving propofol and you're starting to see them excitement, I kind of push a little bit more. You kind of try to push them through. With an inhalant, you can't really push them through. Like they just have to inhale it and then it has to kick in. But with an induction, with an IV, you can push a little more drug and get them through excitement. And then stage 3, plane 1, that is your light anesthesia. So now we're under general anesthesia, where they should be. No, Sean, for this test, it's not, I know I'm talking about drugs, but this isn't over drugs. So you're not going to need to know drugs per se on this test. Now, you know, that's what we're moving on to next, but I'm kind of trying to introduce the names of the drugs so that when I kind of talk about the drugs, you might be able to associate what I was talking about. So yeah, you won't have to know drug names. Does that make sense?
Yeah, it does. And I've been making notes. I just didn't know how, you know, how
Yeah,
far
no,
into that we were just yet.
yeah, no, it's good. I'm kind of trying, I mean, it's interesting because I have talked about drugs because you need to know them for radiology, but I haven't done my full like drug spiel, which is what we do next. But hopefully when I talk about the drugs, maybe you can tie it back into some of this information. So, but good question. Thanks for asking that. So your stage 3, plane 1, light anesthesia, this is usually at induction. They should be unconscious, but they're not like ready for surgery. So again, you diminished blink, diminished pedal reflex, but you know, those are probably still present. Again, swallow should be, this is when swallowing will disappear, the laryngeal or swallow reflex. And this is where we intubate. So this is where you pass the endotracheal tube. And then you're going to usually, again, there's always different protocols, but usually when you pass the tube, you're going to hook them up to the anesthetic. And when they start inhaling the anesthetic, that's what's going to move into your maintenance. And then they're going to move into stage 3, plane 2, which is surgical anesthesia. This is where you want your patient to remain. So now the other thing I haven't mentioned is cardiorespiratory. You know, when you start to move into stage 3 plane 1 and then to plane 2, the heart rate should start to come down and the respiration is going to come down because now they're deeper, they're under more anesthetics, and we're diminishing. Again, how much it's going to go down kind of depends on your drug protocol, which when I get into drugs, I talk about those effects. I used to talk about drugs before I talked about monitoring, but I think it makes more sense to understand monitoring, and then you can understand the effects. So surgical, diminished cardiorespiratory, obviously they should be CNS depressed, which we don't want them aware in stage 3 plane 2, surgical anesthesia. Then stage 3 plane 3 is deep anesthesia. Again, survivable, but you're going to further diminish cardiorespiratory. You're going to probably have lower blood pressure. Obviously, stage 3 plane 3, absent reflexes. Okay. Are you taking her car? Yeah. Okay. So you're going to have diminished reflexes pretty much, gone, you know, so I don't expect palpebral, loose jaw tone, diminished, further like cardiorespiratory depression. And when you start to see that what you'll probably see is that your patient is continuing to decline in heart rate and respiration and loose jaw tone. This is a point as an anesthetist, I'd probably turn down my gas a little bit to try to lighten them up, you know. So I try to hover here. I know when Madison was talking about her case the other day, and she was like, you know, we're at 3% and a little bit higher, but you know, her patient was reacting and that patient maybe needed to be higher, you know. So if you're seeing no reaction to surgery, no jump in heart rate, no jump in respiration, blood pressure's going down, things are going down, that's an indication I could probably turn my patient down and try to get in a stage 3 plane 2. And stage 3 plane 4 is early overdose. So we're really starting to get a change in respiratory character, probably dilated pupils, extremely loose jaw tone, your heart rate's diminishing, blood pressure's going down. And something I forgot to mention, I can't believe it because it's like my favorite thing, eye position. When they are in stage 3 plane 1 and plane 2, their eyes should be ventromedial. So they're looking down towards their nose. And as they get closer down here, those eyes are going to come back up. Now, remember, I said there's only 2 times an animal's looking at you during anesthesia. They're either extremely light or they're very deep and we're getting into like places I don't want to be. And the way you determine that, like a fork in the road, what's my respiration, heart rate, respiratory character, jaw tone, you know, look at your other parameters. You can't just look at one thing, that will back it up, you know, especially now getting into these tests. I'm going to start to give you scenarios. I'm going to start to give you case examples on the test. And so if I'm explaining a variety of parameters, what direction is it pointing you in? And then stage 4 is pretty much overdose, almost cessation of breathing. You really start to, one thing I didn't mention to you guys is ECGs are difficult to interpret. You know, it takes practice. And sometimes students are like, I don't know what to look for. Sometimes it's a gut feeling. And one thing as an animal is starting to get, when I've had patients that are getting like what I call ready to check out, like I'm getting into, they're too deep or something's going on. Sometimes the ECG looks wide and bizarre. It starts to get spread out and your PQRS starts to widen or it gets rounded. And sometimes I've just looked at an ECG and I'm like, I don't like, it's looking really strange. Sometimes I'll turn them off and try to lighten them up. And sometimes I've been wrong and the patient got really light and I'm like, fine. Remember, it's, you know, most doctors are going to tell you better light than dead. It's better to err on the side of maybe my patient, I can get my patient back to sleep. I'd rather err on the side of I'm going to lighten them up versus, oh, it's probably nothing, and they are getting too deep. So again, sometimes the ECG looks just weird. It's a hard thing to explain. So what are the objectives of surgical anesthesia? Basically, the patient, we don't want them to feel anything, not feel pain, not to move, but to have adequate vitals. It's like, good vitals, but not moving, not recognizing that something's going on. Again, if they're cutting and the patient's huffing and puffing and the heart rate's going up, that's maybe they're feeling something. Oh, Sean, go ahead.
Okay. Sorry, I've been reviewing and trying to make sure I know what's going on. So you talked about sometimes during the procedure, like when they're doing specific things, like maybe cutting the testicles or pulling this or pulling that, that sometimes that increases the heart rate. But I think I heard someplace else that it also can decrease their heart rate. So I'm a little confused on that.
Well, I will give you this happened to me, and I was helping in surgery a couple of weeks ago, and it was during a neuter. I'm trying to remember who it was.
It was that Blitz collie dog.
Yes. And we got into surgery, and all of a sudden, and she's popping the testicle out, she's cutting the tunic, which normally I get a huff and puff and a tachycardia. And all of a sudden the heart rate just was kind of going down. I got into the 40s. And now, normally what you're going to see probably 9 times out of 10 is the tachycardia and the huffing and puffing. My only theory,
Okay.
so that's what's happened most of the time. My only theory in Blitz, of course, Blitz hasn't read the book on what you're supposed to do, so it's Blitz. It's a collie mix, but it could have been a spike in blood pressure, which if there was a blood pressure spike, sometimes it can cause a bradycardia. But now the cuff was not set to read, so I didn't have a blood pressure at the time it was happening. But it also could have been a vagal stimulation. Sometimes during surgery, if something triggers a vagal response, you get that bradycardia. And that's why I decided to go with atropine. Now I did turn him down, and then I gave the atropine, and then his heart rate came back up. And then after I turned him down, his respiration was starting to go up again. So then I had to turn him back up a little bit. So
Okay, so Blitz is pretty much kind of an exception to the rule based on quote unquote breed specific response.
I feel like, this is just my gut reaction to Blitz.
Right.
And maybe, I try to look at every patient individually and not prejudge, but anytime I have a collie mix, they just tend to be sensitive. And it was interesting because I wouldn't expect that response during that part of the procedure. I would expect the tachycardia and the huff. And a lot of times those patients, they huff and puff, and as soon as they're done clamping, everything kind of goes back to normal. It's just, as you help with neuter after neuter after neuter, you're going to start to see a pattern. Like when they do this, and when they let go of the clamp, they do this. And you that's why I'm saying most of the patients don't drop their heart rate. But if they do have a blood pressure spike or a vagal stimulus, you can see a drop.
Okay. Thank you. That clarifies it because after reviewing, I was like, wait a minute, does it go up or does it go down? And now I know what the quote unquote conditions are. So
yeah, all I could do when he dropped his heart rate, like I said, my gut was, we've been under a while. I'm going to turn him down because it was a pretty fast drop, which usually you see with vagal response. But in the meantime, I also was like, I'm going to turn down the anesthesia in case it's, for some reason, he just got excessively deep like that, which normally doesn't happen. But if I take the anesthesia away, he responded well to the atropine, blood pressure was good. And then when he huffed and puffed, I was like, okay, you're light again. Let me turn you up a little bit. And we kind of found a happy medium after that. So he was a bit of a roller coaster. And I think he did the same thing for his dental. He kind of gave them some issues when he was a dental patient. So there you go. But good question. Physically, and mechanically assess circulation. So physically is like listening to the heart, putting your hand over like an apical pulse, which is feeling the heart in the chest. You know, so physically is like listening with your stethoscope. Mechanically, which would be, our EKG, and, our blood pressure machine. So doing a blood pressure, having an EKG, an esophageal stethoscope, even though like it's a piece of equipment, so I think mechanical, you're listening to the heart. And again, I always, some of the students that are in surgery were talking to me in my class, and they're like, man, this ECG's just been all over the place. And I always say, I only use the ECG to monitor electrical activity, and what you hear is always going to be your most accurate. You have to look at your EKG and make sure they're not having an arrhythmia. But again, if the leads get dry, if they fall off, or sometimes Dr. Ritz or someone's scrubbing and ECG's like all over the place, it's not going to give you an accurate heart rate. It's not going to give you an accurate reading. But anytime an EKG looks funky, it's the best way for me to put it, I put my stethoscope in, esophageal or regular, and confirm, is that what I hear? And that's the best way to back up. So you should always be using that. What are causes for the following and how could you treat? So bradycardia, which we were kind of just talking about, can be vagal stimulation. So, sometimes surgical stimulus can cause a vagal stimulus, especially like GI surgery. If you do like a gastrotomy or an enterotomy and the doctor's tugging on the intestines or the stomach, the vagal nerve runs right through the trunk of the animal. Sometimes esophageal surgery or thyroid surgery, the doctor has to retract the esophagus. Sometimes when they tug on the esophagus, I've seen a drop in heart rate. So there are certain procedures. Now, a neuter, like I was just telling Sean, is not one that I typically would expect vagal, but there's not a lot of things that drop the heart rate that fast. So again, you treat with atropine. That's why I gave Blitz atropine. So bradycardia can be excessive depth. They're just too deep and the heart rate's going too low. Dexdomitor. So if dexdomitor is part of your protocol. Now, what I've told you guys for radiology is the bradycardia is worse in the first like 20 to 30 minutes after you give it. Then it's going to start to wear off. You'll start to see that heart rate should start to come up. Now, Blitz had dexdomitor as the pre-med, and he was very bradycardic in the prep room. But by the time he got bradycardic in the OR, it had been like an hour and 15 minutes or more since his dexdomitor. So I knew at that point, I'm like, I don't think this bradycardia is dexdomitor's fault anymore. Dexdomitor's pretty much, that effect should be worn off. So now I'm looking at other reasons. Vagal, hypertension can cause bradycardia, and hypothermia. So if they're too cold, the heart rate's going to drop. Now, how you treat it, what's the reason? If it's from hypothermia, you got to warm them up. If it's vagal, you have to give them atropine. If it's increased depth, you turn them down. Now, in Blitz's case, I was assuming vagal. I gave him atropine. If it's hypothermia related, you may still have to give them atropine, because if you warm them up, they don't just get warm. They just don't go from like 95 degrees to 100. It takes a while. So in the meantime, you can always try to warm up your patient, but you may still have to give atropine to increase the heart rate. So, and then if they're tachycardic, pain and light anesthesia are probably my top two. They just are maybe not enough anesthetic. Pain response. Sometimes tachycardia can happen with low blood pressure. Now think about this. When an animal gets really vasodilated, and that means, a lot of the anesthetics cause vasodilation, that means there's less pressure in the artery. Usually you'll get hypotension which is low blood pressure, the heart's natural reaction is to try and pump faster to try and reestablish blood pressure. So sometimes I have an animal that's deep and has a really crappy blood pressure, and the heart rate will try to compensate. So the thing to worry about with tachycardia that I don't want you to always assume they're light. I don't want you to always assume they're painful. I mean, those are my top two. But if it's really because they're too deep and they're hypotensive and they're not blinking and they're not, usually if it's pain, they might increase their respiratory rate at the same time. So that usually helps you determine if that makes sense. And again, you have to treat the problem. Like one of the reasons, if they're tachycardic because of low blood pressure, a lot of times we give a fluid bolus, and the fluid bolus will help like boost, add volume. And if you add volume, you increase pressure in those vessels. So that's why we do a fluid bolus, sometimes for hypotension. And sometimes the fluid bolus, like I told you guys, the foreign body I did, the dog was vomiting, dehydrated, the bloodhound, he had a heart rate of like 180. As soon as I started pushing fluids, and we had to push fluids for 20, 30 minutes, that heart rate started to come down because we were reestablishing hydration, reestablishing vascular volume. Now, if it's pain, like when I was talking to Madison about her case and, the reaction the dog was having, and they ended up giving more drug. Sometimes if it's pain, now you can turn up the gas anesthesia, but I haven't gotten to this in depth. Gas anesthesia has no analgesic effects. So when you keep turning up isoflurane, it'll make them go asleep. I mean, it'll make them stop reacting. The problem is it's just masking it. It's making them not able to react. It's not treating the pain. So when you turn off the anesthetic, whatever made them painful, they're going to feel it. So normally, if I have a patient that I'm having trouble keeping asleep, a lot of times I'll ask the doctor, can I give the dog more morphine or buprenorphine or, so again, you have to get, and again, if the patient's too light, then you do have to turn them up. So, so are there any questions about that? Bradycardia, tachycardia? Okay. Why is it beneficial to use an esophageal in conjunction with an ECG to monitor your patient? What I've said is your esophageal stethoscope is a tube. Remember, it passes in the esophagus, and you pass it in the esophagus and you try to get the tip of it near the level of the heart. And then it'll beat against the esophagus and you can listen. But it will always verify your rate. It'll verify like the rhythm, and it'll verify if your EKG is accurate, and I gave you that example of PEA or EMD. It doesn't happen a lot, but again, I've seen cases where the ECG was normal, but you couldn't hear a heartbeat. Now, both of the main times I saw that, it was a euthanasia on the table, but we also saw it in a trauma case. So it's like, I have seen it, and that's just, when you see it happen, you just realize, always listen. Always listen. Be familiar with the following arrhythmias. So again, a sinus arrhythmia, do I need to do an EKG if I feel like a dog has a sinus arrhythmia?
No.
No,
No.
it's irregularly regular.
Amen. It's a regular irregularity. And, I was watching Bo and AJ the other night and feeling their pulse. And whenever I talk about something in class, I just do it with my dogs. And yeah, both have a very prominent sinus arrhythmia. As long as it follows respiration, it's normal. And usually seen in the healthier dogs if they're fit and healthy. So it's not like it's an old dog thing, and not like, big dog. It's thoracic pressure. So when they inhale and exhale, it changes thoracic pressure and it affects the heart. First and second degree block. I did not add third degree. First degree is that PR interval is wide, but it is a PQRST. It's just the P to the R are farther apart, and that's a bradyarrhythmia, sometimes seen with drugs, especially dextromethorphan. Second degree is where you start to have a P wave without a QRST. Actually feels like a dropped pulse. So, and again, those are treated with atropine. A VPC, or VPC, PVC, people call it, whatever, wide and bizarre, kind of like an upside down. You generally don't feel a pulse for it either. You'll see a tracing and you feel like a skip beat. If you're watching your pulse oximeter, little pulse wave, when they have a VPC, you lose a pulse wave on your, so a lot of times those waves are coordinated. Whenever you have a VPC, you don't have a pulse on your pulse ox wave. And that, a lot of times I will tell you, VPCs for a large amount of patients, if they're having them once a minute, once every 2 minutes, it's usually not a problem. The big thing with VPCs, even heart block, is it affecting the blood pressure? If you're seeing an arrhythmia and you're seeing rapid changes in blood pressure, the doctor is going to be more leaning to treat. Sometimes a VPC, most of the time they're not treated unless they're having like runs. If they have many in a row, it's treated with lidocaine. Obviously, I don't do that. I check with the doctor, I'll give atropine a lot of times by myself. I mean, in Blitz, Dr. Ritz was doing surgery and I was like, I gave atropine. Can you guys still see me? My computer just did a weird thing.
Yeah, we
Yes.
can still see you.
Okay, sorry. I don't know what that was. I just gave it. And then I told Dr. Ritz, I said, I gave atropine. And she goes, okay. I'm like, I'm just, as you get more comfortable with your doctor, you can do those kinds of things. Now the atrial fibrillation, it's a vibrating baseline. So you'll sometimes, and it's more of a tachyarrhythmia. It's a faster heart rate. You can generally see a PQRST. Sometimes you can't see the P. It can be okay. Ventricular fibrillation is where you just get the squiggles, and that's complete disorganized electrical activity. There's no coordinated pulse. Those are the ones you have to shock, and you're trying, at least the dog still has electrical something. At least when you see fibrillation, we kind of have a chance. We can get it back into a coordinated rhythm. And what's very eerie, I got to do some open chest surgeries when I was at Purdue, and we saw a heart go in fibrillation. When you actually look at the heart, it looks, they call it a bag of worms. It looks like a sack, and it's just like quivering. Instead of going boom, 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 the heart's just going, and that's what you're seeing. We had internal paddles, and we shocked the heart with the internal, and then you could see the heart go. It was really pretty cool, but it's very eerie to see a heart that's just like come on, you got to beat. So no pulse on that. And then I already talked to you about PEA or EMD, which is the normal EKG, but no pulse, no heart sounds. And again, if you don't hear the heart, it's not beating, it's not pumping blood, the animal is dead. So an ECG can look super pretty, but if you can't hear a heartbeat, that's accurate. So normal CRT for a patient should be less than 2 seconds. What are we assessing? It's perfusion. So we are assessing the ability to get blood to the very, very tips of the blood vessels, which are the capillaries. And why could it be extended? So you could have low blood pressure. It could be from dextromethorphan drugs that cause vasoconstriction. So I will tell you, your radiology patients, I've warned you, they will probably be pale, and they will probably have an extended CRT, and that is an effect of the drug. The most important thing was, did the patient look like that before you gave the drug? Let me back up to one thing real quick. When I talked about heart rate, you have to evaluate the level of bradycardia, especially because dogs are all over the place. The bigger the dog, the slower the heart rate. But what was their pre-op, no drug heart rate, physical exam? And then if the heart rate I get drops to 50% of the physical exam heart rate, I'm concerned. So if the dogs had a heart rate of 140, 50% of that is 70. If I get down to 70 in that patient, And that's just kind of a way, you know, to give a guideline, because again, dogs are all kind of all over the place with like a normal, you know, cats should not be below 100. Any cat. I can't really say that for dogs. People used to freak out when dogs had a heart rate. They said, don't let the heart rate go below 60. That's very old timer, what I learned a long time ago. But what if it's a Great Dane? 60 is a pretty good heart rate for a Great Dane. If it's a Chihuahua, probably not. I don't like that. But you see what I mean? You have to evaluate the dog. You know, I can't just say there's a magic number. Now in a cat, you don't really want them below 100. So reasons extended: lack of blood pressure, cold, the patient can be hypothermic, low blood pressure, hypovolemia. So if they're really dehydrated, that, you know, the blood becomes sludgy or thick, and so it doesn't get to the tissues as well. So dehydration, hypothermia, can happen from bradycardia, and then like that hypotension or low blood pressure. What does blood pressure measure, BP measure? Number 9, it's the pressure in the systemic arteries. So the pressure in the arterial system. And what's the difference between systolic and diastolic? Systolic is the pressure during the heart contraction or systole. Obviously, that's why that number is higher. Diastolic is the pressure in the arteries during diastole, or when the heart's relaxed. That's why the number's lower. There shouldn't be as much pressure during diastole as there is in systole. If those numbers match, that would be maybe venous overload, fluid overload would be maybe one of the situations I could think that could happen. And then your mean is the average through the cycle. And again, you don't add 120 over 80. You don't add them and divide by 2. It's a special calculation. But the mean arterial pressure, and the minimum is 60. I don't want my mean below 60. I don't usually like the systolic below 100, and I don't like my mean below 60. So those are kind of like, and diastolic we don't usually pay attention to. The most important is your systolic and your mean. And what peripheral arteries can we palpate? So just be, you know, in the PowerPoint, there's femoral artery, dorsal pedal, lingual, carpal. If you've got a rabbit or a pig, you can use the aural, which is AURAL, the ear artery. And in a horse or a cow, well, in a cow, you can use coccygeal, which is their tail artery, but they have facial arteries. So like the transverse facial, the mandibular artery. Again, in a horse, you're not going to be putting your hand up under their back leg. You're not going to be able to find the femoral artery. And you don't want to be at the back end of a horse anyway. So the facial arteries is what you're going to use if you need to get a pre-op pulse on a horse. What's the difference between direct and indirect blood pressure? Direct is a catheter in an artery. It's hooked up to the monitor using something called a transducer, but it's in an artery and it's measuring continuous blood pressure, which is the most accurate. You'll use this in horses, in research, advanced small animal surgery. And then indirect is what everyone will use in surgery, which is it's called oscillometric or Doppler. Those are 2 kinds. The oscillometric is the cuff that, you know, you go to the doctor, they put on you, or a cuff, you know, or the Doppler, which you put over an artery. And it's indirect because you're measuring outside the animal. You're not in an artery. You're getting an estimation. 2 reasons for hypotension, 2 reasons for hyper. So hypotension, which is low blood pressure, tension, pressure. Low blood pressure, too deep under anesthesia, vasodilation from certain anesthetics. Also blood loss, you know, if they've been through, you know, if they're in hypovolemic shock. Hypertension, when you have high blood pressure, normally it can be a reaction to drugs, but I usually think they're light, not adequately deep. So when they hurt, they're going to get a spike in blood pressure. Dexdomitor causes hypertension, so it could be a drug. But the most important question, number 13, how do we treat hypotension? Well, you have to get to the cause. You know, I can't say if it's like, if they're too deep, you turn down the anesthetic. If they're too deep and vasodilated, normally what I do is I turn down my anesthesia first, because anesthesia is a vasodilator. And sometimes I'll give a fluid bolus. I'll bolus, you know, a certain amount of fluids. And sometimes that's enough. You can get into drugs like dopamine and dobutamine and phenylephrine. Those drugs are called positive inotropes, and they can, you know, cause the vessels to constrict and increase pressure. But you know, most often you're going to turn down your anesthesia and you're going to give a fluid bolus. So hopefully you guys had that. Mechanical, physical ways we measure oxygenation. So mechanical, you know, or sorry, physical, you can actually look at the tissues and are they pink? You know, we shouldn't see cyanosis, we shouldn't see blue, purple. The other way or mechanically would be with a pulse oximeter, and that's what we put on the tongue. Now, mechanically, you can also do a blood gas. I didn't get into, again, deeply about blood gases, but then you can draw an arterial sample. If they're pale and cyanotic, if they're pale, I'm thinking blood loss. You know, it can't, or, you know, they're anemic, or, you know, if they were hit by a car and they lost blood, or if it's a hemoabdomen, if a dog comes in and their spleen ruptured, they're going to be pale because all their blood's going into their belly. Cyanosis is a lack of oxygen. And that's indicating cyanotic is they're not getting oxygen to the mucous membrane. So, you know, do they have pulmonary edema? Do they have a pneumothorax? You know, anemia can affect, obviously, hemoglobin. And if they're not getting enough hemoglobin, they can't carry enough oxygen. But usually cyanotic is some issue getting oxygen in and getting it to the tissues when they look a little purpley blue. 2 ways oxygen is carried in the blood for 16. Oh gosh, I'm gonna try to go through these quickly. Do you guys have a class after this, or can you stay a little bit?
We have an hour break between your class and our next class.
Are you okay if I just keep going over this? Okay.
I am.
I don't
Okay, I'm just gonna keep going. Sorry, I'll try to hurry. Oxygen is carried on hemoglobin. That's the majority of oxygen is bound to hemoglobin, and then some is dissolved in the plasma. So, okay, good. If you absolutely have to go, I get it. This is recorded, but hopefully you can stick around. My next class has a test, so I'm free too. So it's dissolved in the plasma, but it's mostly bound hemoglobin on red blood cells. Your SaO2 is measuring, remember, SA, saturation, A, arterial. That's taking an arterial sample, and that's how much hemoglobin is actually saturated or bound with oxygen. PaO2, which is partial pressure in the artery, is how much oxygen is dissolved in plasma. Now, again, your saturations are always your most important number because that's how majority of the oxygen. But anytime you see SA or PA, you have to draw an arterial sample to assess that. What does a pulse ox measure and what's normal? A pulse ox is an SpO2, which is saturation, and think P, pulse O, ox2. So saturate, that's how much hemoglobin is saturated with oxygen, but it's an estimation because you're putting this on the tongue and it's not measuring directly from the blood, but it's a very accurate reading. Normal SpO2, if you guys remember, I put that chart on your Moodle page, that little handwritten sheet. 95 to 100% is normal. 90 to 95 is, I'm getting low, investigate. If I'm 85 to 90, I'm getting into danger level. At 85 is my absolute, don't want to be below 85. You know, if I'm 85 to 90, I'm very concerned. You know, and 90 to 95, I'm like, what's going on? What are 2, and I should have put a question on here, but I want you guys to be able to tell me, based on that SpO2 troubleshooting sheet, if you get a 92% reading, what do you do? Do you run to Dr. Ritz and go, oh my God? Or do you look at Mrs. Long and go, remember, you check your probe. Is it dirty? Did it fall off? And I usually take it off and put it back on. Sometimes a couple times. If you take it off and clean it and wet the tongue and you keep getting 92 and the pulse rate is matching my heart rate, I tend to believe it more. Sometimes you get 92 and the pulse doesn't match your patient's pulse. That kind of tells me, is it inaccurate? Is that a problem? Is it oxygen? If the animal, now your radiology patients aren't going to be on oxygen. But if I had a patient in anesthesia having a spay and they have a tube in and they're getting 100% oxygen, is my tube kinked? Did my oxygen shut off? Did a hose come unhooked? And then if all of that checks out, I can tell the doctor, well, oxygen's getting to the patient. My probe is accurate. Is there an issue with perfusion in the animal where oxygen is getting to the lung, but like if an animal had an embolus where that blocks the blood flow to a portion of the lung, that area is not going to oxygenate. No matter how much oxygen I get there, it's a circulation in the lung. So then the doctor is going to have to, do some investigating. But I do want you guys to be able to tell me common reasons on this test for low oxygen or low pulse ox, but how would we troubleshoot? What are the steps to doing that? 2 locations for the pulse ox. Obviously the tongue is number 1. You can use a rectal esophageal probe. If you can't do one of those, you can do the inside of the lip. Just make sure the light doesn't shine through the fur side. The light should always be on the mucous membrane. I like to shine from under the tongue because it's smoother than the top of the tongue. If you can't do that, prepuce or a vulva would be my next best spot. And then if you can't do that, you can try to do it in between their little toe web. Sometimes cats, if they have a nice little pink paw pad, I've put it on their little paw pad. And sometimes over the Achilles tendon, if they're really thin. So, you can kind of troubleshoot some different areas, but be familiar with that. Are there any questions on pulse ox? Okay. How do we mechanically, physically assess ventilation? Okay. Physically, watch them breathe, watch them raise their chest. Obviously you're going to count a respiratory rate. You can visualize that. When they're asleep on gas, you can watch their anesthetic bag move. So visualization of the chest or visualization of your rebreathing bag. Obviously you listen with a stethoscope and you can hear the respiratory rate. The nice thing is if you get a good esophageal probe placement, sometimes you can hear the breathing through the esophageal. Mechanically, you can use what's called a respirometer, which is what basically, remember, it was an apnea monitor, which you hook up and it'll detect if they're not breathing. You can set it for a minimum. But the best one is the end-tidal CO2 monitor, which is the capnograph. And the capnograph is going to give you your CO2 reading, but it will also give you a respiratory rate. So and then you can get also a visualization of the respiratory tracing. So you can get a lot of information from that. Now, assessing ventilation, if you put SpO2 here, SpO2 is measuring oxygenation. You hope if your animal is ventilating normally that they're oxygenating, but you can have an animal breathing normally, and if they have an issue with hemoglobin, or if they have an issue with blood loss, or blood pressure, it can affect your oxygenation, and it's not a ventilation problem. So it's really, SpO2 is not a ventilation monitor, and hopefully that makes sense. What is the difference between monitoring rate versus character? So obviously the rate is just how many times a minute are they breathing. If you remember, I said 6 is my absolute. If they're breathing 8 times a minute, I consider that kind of low. it would be super low in a cat. You know, cats are somewhere like 20 to 40. In a dog, they can be 8. But if they're breathing 6 times a minute, which some of your radiology patients, when you heavy sedate them, they could be around 6 breaths a minute. That's kind of my cutoff. You know, if they're 4, I'm really watching them pretty close to be like, that's pretty low. But that gives you an idea of rate. But character is it a normal ratio? If you remember IE ratio, is it, you know, shorter inhalation, longer exhalation? Is there a lot of abdominal effort? So normally the abdomen is really just used kind of to exhale. But if they're like, and really sucking in their belly, or I get, you know, another respiratory pattern that I don't like is a rocking it goes, it's a 1-to-1, you know, where inhalation and exhalation are equal. That can be pain, that can be CO2, you know, could be pulmonary edema. So that's not a good pattern either. So you want that inhalation, exhalation, pause. And that gives me, like I said, when an animal is getting excessively deep, too deep, danger deep, they tend to have a little more abdominal effort. They start to recruit their abdomen for breathing, and that's kind of concerns me. What's the term for elevated CO2? That's hypercapnia. You may have put hypercarbia. You can use them. Capna or carb both pertain to CO2. And what causes this during anesthesia, and what do you do to treat? So elevated CO2 is usually they're not breathing enough. So I tend to see it during anesthesia. It can be they're too cold or too deep. When they're cold and deep, they're not going to breathe as often. And that means they're not getting rid of CO2. So they're too deep. But mainly the problem is they're probably hypoventilating. They're not breathing enough. So how do I treat? Well, if I think they're not breathing enough because they're too deep, I'm going to turn them down. If I think they're hypothermic, I'm going to try to warm them up. But the problem is, remember, they're not going to warm up rapidly. So in the meantime, I'm going to ventilate for the patient. Now, I told you guys normal is like once every 3 to 5 minutes. You just give them a sigh breath. You may have to breathe for them once a minute until, you know, they come up. Now, normal, I told you, is like 35 to 45. So anything really over like 50, I consider hypercapnic. Probably my worst, I had a patient that was up that, what's wrong, baby? Rose, I got something stuck in his nose. Normally, sorry, I lost my train of thought. Normally when, you know, if they're in that, you know, that high CO2, the dog that I had that was in the 80s had a lot of opioids on board and was severely respiratory depressed. So I was ventilating a lot more. The higher the CO2, the more you have to ventilate. What is the term for low CO2? Now that would be hypocapnia or hypocarbia. I tend to use capnia more. What causes this during anesthesia? Now, it can be overventilation. Maybe you just went gangbusters, and if you bag them a bunch in a row, that CO2 will drop. Now, remember, they need a CO2 of at least 40 is their stimulus to breathe. So sometimes I bag them a bunch, and we were talking about Madison's case where, you know, she bagged the dog and then it would stop breathing for a period, and then it would start to bag, you know, breathe a bunch. And I wondered if, you know, the dog would kind of hyperventilate for a moment, bring its CO2 down, and then stop breathing. And then all of a sudden it builds back up, and then it starts breathing. And sometimes I do get patients that are in that, I don't like those patients because I can't get them in a normal, you know, like I told Madison, or in that case, you can try to take over. If you had a ventilator, I might put them on a ventilator, or I might just bag more regularly for them. But sometimes the low CO2 is too high of an oxygen flow, or they recently hyperventilated and brought them down. Now, the way to treat it, this one's a little more difficult, is back off with ventilation. You know, if you stop breathing for them, their CO2 should start to come up. You can turn down your oxygen flow, but you can't turn that down too low. Normally patients are at 1 liter of oxygen. Normally, I might try to go to like 0.8 liters or 0.5 liters and see if that makes a difference. The other thing that's not on here, sorry, I should have put a question in section 2. If you remember, there was a difference between, now if an animal was slow breathing, that's bradyapnea, and that's slow breathing. You deal sometimes with tachypnea and hyperventilation. Tachypnea means they're breathing fast, but it's shallow. So it doesn't, and sometimes when they're getting deep, they'll do these little choppy, short breaths. If they're feeling something or they get a little light, they'll breathe fast and deep, and that's hyperventilation. Hyperventilation is fast and deep, where tachypnea is just fast. So that's the difference between tachypnea and hyperventilation. I'm trying to think if there's anything I didn't cover, or do you have any questions based on that? Oh, your CO2 values. I told you normal for exhaled or end tidal is that 35 to 45, but remember the machine also gives you an inhaled or inspired CO2, which is 0 to 2. They shouldn't be inhaling carbon dioxide. If that number is going like 8, 10, 12, for some reason they're getting CO2. It could be that something's hooked up wrong. It could be a monitor malfunction, or maybe someone didn't change the soda lime. Those little rocks have to be changed every so often. And maybe, it should remove the CO2 from their gases, but if it's expired, it doesn't work. They could re-inhale. So sometimes after the procedure, I'll change the soda lime and, see if it makes a difference. I'm trying to think, what have I not answered? So the main thing for this test is, what do we expect is normal? What are some reasons when things are abnormal? But the big thing is, what are you going to do about it? And if you identify, so I'm kind of ticky-tacky when I grade this. If you tell me the SpO2, if it's a probe issue, and then you tell me, I say how to treat that, and you say bag the animal, well, bagging the animal doesn't fix the probe. If you identify a problem, the way to fix it should be related to the problem you identify. So there has to be a connection, if you see what I'm saying. Does that make sense?
So I have a question based off of that comment. So like earlier when we were talking about like tachycardia and all that, so will you want us to put like all the things that could possibly be causing it and the explanation as to how to fix it, or just 1 or 2 examples?
It may be just, usually when I have questions like that, it's kind of like, what's 1 or 2 reasons this might happen? What can you do? So usually I'm not saying like, tell me everything. Because like SpO2 troubleshooting, there's a lot in that. There's a lot of reasons, but I'm not expecting you to list like every single thing.
Yeah.
But usually I will say my essay questions are layered. So there's kind of usually multiple parts. And I'm glad you brought that up, because sometimes on tests, people will read the first part of the question and they don't read the whole thing, and they'll only answer. I do give partial credit, so it's not like you have to get the entire thing correct, but make sure you're reading everything I want. And think about when you explain your answers, say you were explaining it to a newbie, like in your kennel, or you were explaining it to a coworker that you're training. You don't want to just assume. I want you to, it's hard on essay. Some people give me a novel and some people give me 3 words. And now sometimes you can get your point across in 3 words. And some people have to explain it. And you got to do whatever you got to do. But sometimes I get these really short answers that just don't, I have to assess your train of thought. So put yourself in my shoes. Could you read your answer and that could you train somebody based on what you wrote? Sometimes I'll give the answer back to the student and say, if you didn't know what you were doing, could you follow what you wrote, and would that adequately tell you what to do? And sometimes they go, yeah, that doesn't make sense. And I'm like, that's how I want you to kind of approach these questions. You know, like I said, my tests are always multiple choice, true, false, but there is, in anesthesia, there's a fair amount of essay questions just because I have to assess a thought process. Does that answer your question?
Yeah, it does. Thank you.
Uh-huh, hopefully. Any other questions? Okay. It'll be open on Teacheries. I'll email you about the timing. We won't have class tomorrow. The video, oh, let me show you one thing real quick. I know, don't leave me. Sorry, maybe someone already left, but that's okay. On your Moodle page, let me go back to your Moodle page. And I didn't, there was this chart, and hopefully you've looked at it, hopefully, because, you know, it tells you here's stage 1, and what do we see, you know, in stage 1? And then, so what happens with respiration as they go from, and if you follow at the top, it tells you the parameter. And then if you go down in that column, what happens as they go through these stages? So, you know, what do you expect to see with cardio, depth, pupil size, other reflexes? So this is an excellent, I love this chart. It may help you. So don't forget that this was there. The other resource you had was this monitoring supplemental. Again, this is added in. This is also, it gives you everything we're assessing respiratory, but what I like is bolded is what are normals. Now I know it said 10 to 20 breaths a minute. I gave you my absolute value, but it gives a lot of good information. So again, those are both good handouts that are on your Moodle page. Hopefully you've looked at them. They're there for you forever, so you can always, you know, and like I said, I know some of the surgery students have printed these, especially the one that was the chart. A lot of students put that on their clipboard so that they could look at it during surgery. So, all right, well, again, it'll be open tomorrow. We're gonna move on to drugs on Friday. We'll start that. We'll start explaining anesthetic agents. We'll start with pre-meds, and we'll just go from there. If you need something, email me. If not, I'll see you on Friday. All right, have a good day.